Dipak Ram, who's going to talk to us about the current and future landscape of leukodystrophy.
Thank you, Sarah, and thank you for inviting me. Sorry, I've got my own laptop, so I can't walk around as far as James. It's really challenging because we are in the era of genetics, as you hear, gene therapy, all the things Dr. Eichler is talking about next door. But then we also need to be realistic about what we can offer families at the moment. You know, in the era of gene therapy, there are lots of development, lots of therapies, lots of trials, but the reality is lots of families are still affected by leukodystrophy, which need good holistic care and management. And then maybe touch a little bit about what the future holds. I don't know how that jumped, sorry about that. Let me start. Okay, good. So the first and biggest challenge for our IWMD service is the child even a child affected by leukodystrophy? And you would think, you know, as a family with a child with leukodystrophy or a person with leukodystrophy, that would be an easy question to answer, but the reality is no. The first scan here is a child with a brain tumor. The second child is an adult with an MS. And the third child is a child who just had a viral infection, and when the scan was repeated 3 months later, they were told they had a leukodystrophy, and 3 months later, the scan was normal, and they were back to normal. So they did not have a leukodystrophy, they did not have XALD, which they were told from a scan. So it's really challenging because you can look at scans and they can look like a leukodystrophy. You give bad diagnosis to families, and then you realize that the child didn't even have a leukodystrophy. So the first challenge is, does the child even have a leukodystrophy? And historically, and this is not true, a lot of people used to wait for children to lose skills or adults to start losing skills. And the diagnostic criteria used to say if you wait for beyond 3 months and someone is losing their skills, then you think about doing a scan, find leukodystrophy, and think about further testing. But many people aren't affected in that way. Not many children or adults even lose skills. They may just have problems with their development. So that's a challenge as well, because a lot of people don't think about leukodystrophy when someone is not developing properly. And as clinicians, we are given lots of flow charts. This is a really good flow chart by the team in Netherlands, and talking about pathways of how we investigate leukodystrophy in children. And it's quite complex, and as you can see, it will take a while to get to a diagnosis, thinking about this traditional way of using scans and other things first. But you've heard, a lot of you have come from next door, but you've heard, you know, we are in the era of gene therapy. We are in 2024, we need to move quick. And you've just heard James's talk about genetics and the importance of advances of genetics. This is just to show you a scan of a patient with metachromatic leukodystrophy, so a devastating leukodystrophy that we see. And this is a 2-year-old girl with it. This is a 7-year-old girl with MLD with a normal scan. So the second thing is that the scans don't tell you always that someone has got a leukodystrophy. So as a clinician, you have to realize what the symptoms are, and if you do a scan at an early stage or in a child with a different phenotype from the same gene, they may have a normal scan. And by the time the scan changes, the symptoms would have deteriorated much more. So that's again complex. It's not just as easy as do a scan, find leukodystrophy, get the diagnosis. It's much more complex than that. And what have we learned about treatment options? It's complex. So James has told you about genetics and the basics of genetics. Not everything is amenable to gene therapy. Not everything is amenable to enzyme replacement therapy. But that was what we had to go through. This is just to give you an idea of what we've learned from one condition. So the first thing which was taught about for MLD was that, well, if that you're lacking an enzyme, let's just give you someone else's bone marrow. And we did that, and we found that children still deteriorated with MLD, despite having a bone marrow transplantation, especially when they were the aggressive onset. So what we learned was a normal enzyme level wasn't good enough. And whilst that was being done, other people were doing enzyme replacement therapy, again, not really helpful. Some others were trialing gene therapy by injecting it, so similar to what you will hear with Canavan disease. Some of you may have heard that next door. And none of that worked. So all we had over time for MLD was symptom management. So with the genetics, you have to still be innovative and think about how you can work around it. And for MLD, the way it was worked around, this is a complex slide, but effectively, to speak about it simplistically, you are taking the patient's own stem cells, you are then modifying it in the lab, and you insert a working copy of the gene, and you then switch the gene on to function at 100 times the normal range. Why we do that? Because we know that when we gave a bone marrow transplant from someone to someone else, they still deteriorated. So the theory was, should we be giving them lots more enzyme than usual? And that worked. And that's interesting that in the trials when people were given that at an early stage, so either before they developed symptoms or at very early stages of symptoms in the older children, they didn't deteriorate and they kept their motor function going. And more importantly, you can see this is the cognitive score. So the dark green going up are the patients who were treated, and the light green at the bottom here were the patients who were not treated, who all deteriorated from their cognitive mental capacity point of view. But it's not as easy as that. That's the problem, because it takes time. So it takes 6 to 8 weeks, and if you have a family member with leukodystrophy, that is a long time to wait 2 months for the whole process to be there. And that is after you've taken the stem cells. You still need to make the diagnosis, see a IWMD clinician, get all this done, and then get the gene therapy. And if the patient is deteriorating in that time, it doesn't work. In fact, it can accelerate deterioration. So we have to be cautious that, we're modifying things with the gene, we're doing a lot of exciting things, but we could cause harm to patients if we are not careful. So there's a very strict criteria for inclusion so that we're not causing more problems to patients. And this is just to show you 2 tables to say that, yes, exciting times, we've treated patients with gene therapy in the UK, but most patients are not eligible, and these are all the patients who've been referred to our service in Manchester for MLD who can't get treatment because they're too late. And the main learning point here is that we are still in the era where we need to holistically manage patients. We can't just say, no treatment, nothing to be done. The symptom management is really important. We can't forget basic medicine, holistic care, physiotherapy, speech and language, dietitian, all those things can't be forgotten about. For the later onset patients, that's a bit different. So bone marrow transplant, or what we call stem cell therapy, has still been helpful, but it's given early, and it's really discussed on a case-by-case basis. These are rare, extremely rare. It's not the common forms that we see in the UK. To then complicate it even more, leukodystrophy doesn't always have to just affect the brain. So yes, you can get MLD, which affects the brain, but you can get gallbladder involvement. And it's really interesting because that is independent of what treatment you do for the brain. So you could give gene therapy to someone and cure the MLD from a brain point of view. They're walking around. But if you don't monitor their gallbladder, they could get gallbladder disease and even gallbladder cancer. So the last thing you want to do is forget about the other things which leukodystrophy can do. And it's odd that leukodystrophy can affect other organs. It's not always the brain. So thinking about gene therapy at the moment, we've got licensed therapy for MLD, which is metachromatic leukodystrophy. There are now ongoing trials for other things going on in Northern America. So for Krabbe disease, looking at stem cell therapy, umbilical cord transplant followed by gene therapy. And then for Canavan disease, which probably some of you have just come across from Dr. Eichler's talk, has heard, Canavan disease has also got gene therapy, but the upshot of it is that you want to diagnose patients early. The earlier you are in the patient journey, the better the outcomes are. XALD, so the fundamental condition which started this charity. We've known about it for so long, but probably one of the most interesting and complex condition, like James said. You could have 2 brothers with the same ABCD1 mutation, exactly same mutation. One could develop cerebral ALD, so you could get brain leukodystrophy in childhood. The other sibling could not develop any symptoms and could develop just adrenal symptoms in adulthood. And that's really perplexing because we've just heard that you are using the genes to try and predict what happens, but in some conditions you can't do that. And we are many, many decades into XALD, and we still can't actually predict the phenotype just looking at the gene because it's the same variant, same siblings. And we know that early bone marrow transplant is really vital for those with the brain disease. And the best thing we can do is to monitor them very closely. And then recently, using other therapies. So this is not gene therapy, but thinking about other things we can do to slow down progression of a condition. So looking at pathways. So this is just to show you, as families that, there are other pathways which can affect leukodystrophy. And a lot of them, very interestingly, have a role with inflammation as well, which I'll come to right at the end. So this is just showing you some recent data and trials to say that there are oral treatments now which are being used in trials, which we are recruiting now for XALD. And some patients who may not have stem cell therapy or bone marrow transplant may start this treatment to see whether it holds the disease. And who knows, the future might be that someone is started on this therapy. If you can hold the condition, could you then do bone marrow transplant once they're in the stable phase of the disease? So that's the future thinking, but we're not there yet. Other complex conditions, so there are other leukodystrophies. So Alexander disease is another white matter disease that we see. And this is using a different kind of inverted comma gene therapy, as you would like to call it. What you're doing is you are modifying the expression of the protein through changing the RNA or DNA, which are your building blocks, and that is normally given through a lumbar puncture, so an injection through the back, and you're actually delivering this. And we've done this for other neurological conditions, and the clinical trial, which is now closed, they were recruiting in London and collected some patients, but they're still interested to know if we have any diagnosis in the UK. And that kind of therapy, which is different from the gene therapy I told you about earlier, is being used in a few other trials now and consideration for upcoming trials. Now to complicate things even more. So this is another child, a patient of mine who was 10 years old, had some developmental problems and seizures and started losing some skills. He had a scan done and someone reported saying he's got some changes, blobby white matters, looks like a leukodystrophy, and was looking at that. But actually basic medicine is really important, and trying to look at the child and trying to get a diagnosis, because he actually had a vitamin responsive condition. So he had low folate levels, which is an essential vitamin that we all have, and that low folate levels was what was causing it. So it was sort of almost mimicking what we think was a leukodystrophy that we would call a classic leukodystrophy we see in our IWMD service. But actually the diagnosis was made early and he started treatment and he's responded really well. So very complex. And I alluded to you that leukodystrophy and inflammation are linked. And that, I think, is the essence of our science and understanding of leukodystrophy. So this is just to show you that this neurofilament light chain is one of the biomarkers that we have been using for a very long time in multiple sclerosis, so which is an inflammatory condition, not a leukodystrophy. And for a long time, we know that high NFL levels are associated with disease in MS, and that we used to monitor the NFL levels and see them drop as the MS was under control. And what is interesting is that we have then found that that is related in MLD as well. So now we are monitoring that in our patients with MLD severely, and the patients who've had gene therapy, you see the NFL levels drop dramatically. So we know that actually with leukodystrophy, there is an overlap with inflammation. And many of the physicians here deal with another complex condition, Aicardi-Goutieres syndrome. And again, you can call it a leukodystrophy, you can call it a neuroinflammatory problem, but the essence is that there is inflammation in the cells. So the way we are looking and probably targeting this kind of leukodystrophies in future might be different. Are we going to actually be even looking at immune-based treatment rather than just genetic things for some of these conditions? Who knows? But we have to be really vigilant. I think we are now in a time where we can't spend too long to get a diagnosis, because there might be a potential therapeutic option or a trial which is open. So one of the biggest things you can see here on this flow chart is it's hidden right at the bottom there, saying refer to a leukodystrophy expert center, but we are circling it and telling everyone in the UK that if you have a child with suspected leukodystrophy, please refer them early, because the earlier you get the diagnosis, the better the outcome might be if you could signpost them. And that is really tricky because this is new. And you will hear a little bit more about this through the rest of the day. But the new NHS England IWMD service is now commissioned, and there are hubs for our pediatric referral centers. The adult center is down in London, but there are 3 pediatric hubs. And it's really important that we try and get the message out there that patients need to be referred. And the honest truth, there are many clinicians out there who don't know this service exists, and that they hear it from the first time from the family or from someone in LXTLC who say, refer them here. And the families go, I didn't even know the service existed. The pediatric neurologist's own clinician doesn't know the service exists. And you think that's weird because we all speak to each other. But the reality is everyone is so busy, not everyone gets to read their emails. So when you say a new service, everyone just goes, oh, I've got 1,000 emails, I can't open and read it all. And that's the reality of the modern world. So really getting the message out there that this service exists, these patients need to be referred early is important because, again, I'm showing you this slide, gene therapy, genetics, modifying genes, we are in that era now. And the earlier we get the diagnosis, the better the potential outcome could be for some of these conditions. There's still a lot of conditions without targeted treatment options, but we are in early days. And then just the last few slides to tell you what the reality. I spoke to you right at the start about MLD, and this is the reality within MLD, is that, almost all children in the UK who have had treatment have had an older sibling who has died of the condition. And that's awful, because the only way to get diagnosed is you must have had an older sibling who has been affected by this horrific condition, and all the families tell us that the older sibling saved the younger sibling's life. But we shouldn't be in that. Why are we in that? We are a first world country. Should we not be thinking, how can we move forward from this in the future? And there's only one way, which is, of course, most of you will know, is newborn screening. And that is going to be the future. It has to be the future from escaping from some of these horrific conditions where there is already a known treatment option. And just to give you some perspective that, we are doing some work because none of these are on the newborn screening at the moment in the UK, but we worked on a pre-pilot in Manchester just looking and screening children in our catchment area, so all in our hospital, and we coincidentally picked up a child who had, on their newborn screening, diagnosed MLD, and we confirmed it genetically, and we gave them gene therapy, and they're doing really well. And that's amazing because we can show the government that actually this works and that we need to really persuade the government that, these cases make a difference. Horrifically, within a week of this child getting his diagnosis and starting the gene therapy, being pre-symptomatic, his first cousin, who was older, got diagnosed with awful aggressive MLD. Who made the diagnosis? My patient's father. He told his brother, your child's got MLD because must be that, and the clinician didn't think about it. But it was too late for that child to have treatment. So, it's really difficult to try and get the knowledge out there, and a lot of this may rely on genetics. But a word of caution about that as well, because when you do newborn screening, you might find things you don't understand, that we don't understand. You might have someone who has got one copy of the gene saying that they're going to get, from the mom might be a copy which says you're going to get late infantile disease and you're going to need gene therapy. But the gene from the father may say you're going to get adult onset MLD. What do you do? Do you subject them to gene therapy, which comes with its risk? You're going to condition them, give them chemotherapy. They may get an infection, they could die. Or do you wait? And if you wait, what happens if they develop symptoms and it's too late? So, that is the reason why newborn screening in the UK hasn't just come full-blown like that, because there are lots of ethical things that we don't quite understand yet. And you might uncover conditions that you might tell a child when they're 16, by the way, we did newborn screening, everything's going to be fine, but when you reach 40 or 50, you could get early onset dementia and die. And they'll be like, I didn't want to know that. So newborn screening is not without its risks. When you do genetic kind of screening, you have to be very careful with what we do and what we analyze and what we actually report. So yes, things are changing in 2024. And I think in summary, it's fair to say that leukodystrophy is not always an untreatable area. If we went 10 years ago and you ask any pediatrician or pediatric neurologist, a leukodystrophy was called an untreatable condition. So they used to be seen by pediatricians. There was no rush to get a test. When you saw leukodystrophy, you referred them months and years of getting a diagnosis. That's not the case anymore. But the other important point that a lot of you will know here is that, management is not just a cure. That, you can't just say that because there's no treatment, therefore there's no management of the child. You still need to have a multidisciplinary team looking after the child, the family, and sometimes that doesn't happen, which is why we really want people to get referred to these IWMD hubs. And the therapeutic options can be very varied. They're not all gene therapy. They could be oral treatment, they could be enzyme replacement. And what is interesting is that, yes, they're all leukodystrophies, they're all genetic conditions, but gene therapy doesn't work for all of them. So it's not as straightforward as saying gene therapy is the cure, because as I've showed you, sometimes it's not. There are other things which might be the solution. And I can't stress this enough, get the message out there. If you have a friend or relative or someone else who speaks to you, or someone comes to you as a family with a child or a family member with IWMD, and you say that there is a service out there, get the message out there. The earlier we get the diagnosis, the better the outcomes are, but also the better the management will be, and because there is some advice from an expert team about how to look after these children, who is needed in their care, and the long-term planning, keeping them on a database. So you'll hear a little bit more about that as well. And if a trial opens, the goal would be that all people in the UK would be on a database, and then if a trial or something opens somewhere, we'd be able to find the families, contact you very quickly and say, this is a trial which is open, this is all the patients, and you get to know straight away. So that is the goal of where we're expecting to be in the future. And that note, I'll end. Thank you.